Hello beautiful people, it is Valentina back with another video. This time we're talking about abnormal uterine bleeding or AUB in the context of obstetrics and gynecology, so women's health. And here we're specifically talking about non-pregnant females. So abnormal uterine bleeding is defined as menstrual bleeding that is abnormal in either frequency, regularity, duration, or intensity. So frequency refers to the duration of the cycle. So whether it be anything less than 24 days, which is increased frequency, or anything more than 28 days, which is a less frequent cycle. So less frequent. I just repeated myself. Wonderful. And then in terms of regularity, this is talking about how much variation is there between the cycles and between the length of each cycle. So if there's more than an 8 to 10 day variation, that's considered abnormal, whereas most people might have like a couple of days variation between each cycle. Then abnormal duration is considered more than 8 days. And then intensity can be increased or decreased between cycles. And that's where a lot of people will report using more menstrual products, so more period pads or less tampons, or just report different volumes collected in, for example, their period cups. So the FIGO or FIGO, can't remember what that stands for, developed this system called Palm Coin to remember or categorize the different causes of AUB. So Palm Coin stands for polyps, adenomyosis, leiomyoma, malignancy and hyperplasia, coagulopathies, ovulatory dysfunction, endometrial reasons, iatrogenic, aka caused by medications or treatment, and for not otherwise classified, which is kind of a cop-out, but I guess important to go through as well. So just before we go through each of these, I wanted to quickly revise the different layers of endometrium, different layers of the uterus. So the uterus is composed of 3 layers. The outside is the serosa, which is kind of that one cell thick layer of that covers the uterus. And then we have the second layer, which is the myometrium. The myometrium is made up of smooth muscle cells that contract, or they can contract, for example, during labor and during delivery of the fetus. And then finally we had the innermost layer called the endometrium, which I've depicted here as red because the endometrium proliferates throughout the cycle, which is of course a whole other thing that could be talked about. But the endometrium is composed of glands and lots of blood vessels that are designed to kind of support a growing fetus during pregnancy. And of course, during menstruation or during the part of the cycle where blood is being expelled from the uterus, this is the layer that gets sloughed off and exits via the cervical and vaginal canal. Right, so now coming back to P is for polyps, in this case anyway. And polyps are actually an overgrowth of endometrial tissue. So that's that glandular and vascular layer, innermost layer of the uterus. Polyps can be defined as sessile or pedunculated. So sessile polyps have thick, broad bases, and pedunculated polyps have narrow, long bases. And usually these are asymptomatic, but if they prove to be a cause of AUB, then they can be removed surgically, which through methods that I'll go through in a bit. So next is A for adenomyosis. So here we have endometrial tissue growing into the myometrium, and again, this can cause abnormal uterine bleeding and is treated using non-steroidal anti-inflammatory drugs. Then we have L. L is for leiomyoma. So this is where the smooth muscle cells that are present within the myometrium abnormally proliferate and cause what we call fibroids. So if you hear fibroids, someone's probably referring to a leiomyoma. Like polyps, leiomyomas are normally asymptomatic. They can be found in 3 different parts of the myometrium. So they can be submucosal, so directly underneath the endometrium. They can be within the myometrium, or they can be subserosal, or under the serosa, or the outermost layer of the uterus. If they are symptomatic, they'll usually manifest with an abnormally enlarged uterus and maybe chronic pelvic pain. And so they can be treated by drugs such as these and surgeries, such as uterine artery embolization, myomectomies, and hysterectomies. And again, I'll go through these treatments later. Then we have M. So malignancy and hyperplasia is a big topic, and I'll only briefly touch on it here. But basically, malignancy and hyperplasia occurs in the endometrium, and this is as a result of increased exposure to estrogen, which results in proliferation of the endometrium. So risk factors for increased exposure to estrogen include nulliparity, which means only never having been pregnant or giving birth before, early menarche and late menopause, which means that you begin your menstrual cycle early and you end it late, and so overall you've had a longer period of time exposed to estrogen over your lifetime. If you have polycystic ovarian syndrome, this can also lead to increased estrogens, and other things like obesity, type 2 diabetes, hypertension, and of course hormone replacement therapy and tamoxifen, which are both pro-estrogenic drugs or exogenous estrogens. So in terms of the progression from hyperplasia to malignancy, what usually happens is that benign endometrial hyperplasia is the beginning stage, and this is where you get an increase in stromal and glandular cells. Then this can lead to endometrial intraepithelial neoplasm, which is where you'll get your atypical cells with extensive mitosis and an increased gland to stroma ratio. This can then progress to endometrial carcinoma, which is where you see a pronounced proliferation of disorganized glandular tissue. So the way that this is diagnosed is usually through a biopsy, and by looking at the ratio of the glands to the stroma being the kind of other structural cells, you can tell which category of hyperplasia or kind of malignancy that proliferation falls into. Then we can go into coagulopathies, which I've just named some here. So examples include von Willebrand disease, where you're missing a very important factor in the coagulation cascade. Thrombocytopenia, which is where you don't make enough platelets, and hemophilia. So then we move on to O, which stands for ovulatory dysfunction. I was going to say ovulatory dysfunction. So an example of this would be hypothyroidism, which can lead to an increased production of cortisol and therefore an increased production of estrogen. We can also have polycystic ovarian syndrome, where hyperinsulinemia leads to increased gonadotropic releasing hormone, leading to, in turn, increased luteinizing and follicle stimulating hormone, and this leads to an increase in estrogen as well. And as we went through earlier, this leads to hyperplasia and therefore can lead to abnormal uterine bleeding. Obesity can also result in ovulatory dysfunction. Now, the next thing is endometrial causes, and this is a very important category. So I have two main examples here. We have endometriosis and endometritis, but you can also have something that's simply called endometrial dysfunction, which is kind of this diagnosis of exclusion where your endometrium is dysfunctioning and sloughing off or bleeding irregularly. So starting off with endometriosis, endometriosis is defined as endometrial tissue that's growing outside the uterine cavity. So instead of remaining inside and, being where it's supposed to be and providing nutrients and blood to the developing fetus, it can grow anywhere from along the adnexa, so along the fallopian tubes. It can appear on the outside of the uterine wall, on the ovaries, and it can even kind of appear in other places in the abdomen because the abdomen is an open space. So it can result in adhesions to the bowels, to the peritoneum, and can be very, very complex and cause many complications, including infertility. Clinically, endometriosis usually manifests with pain before menses and pain during sexual intercourse, so dyspareunia. And on an exam, a person might present with rectovaginal tenderness and masses on their adnexa during bimanual palpation. Usually what's seen on a transvaginal ultrasound are these chocolate cysts, which are made up of blood and necrotic tissue. And the treatment includes hormonal treatment, which again we'll go through in a bit. And surgically, what usually happens is you can have non-definitive treatment in the form of excision of certain lesions, cauterization of lesions, and ablation of lesions. However, if these methods are used, the endometriosis or the abnormal growth of uterine tissue can still recur. And so the definitive treatment is the complete removal of the uterus, so hysterectomy, or a bilateral salpingo-oophorectomy, which is talking about removal of the fallopian tubes and of the ovaries. So as you can see, it's actually a relatively common, sorry, I didn't mention this, but it is a relatively common health condition. I think us as girly girls, everyone knows someone with endometriosis, and it's very underdiagnosed and is usually found as a, incidental finding, but it can have really, really big implications for a female, as can all of these, of course. Now, another cause of endometrial bleeding is endometritis, or inflammation of the endometrium. And this is usually caused by these sexually transmitted disorders such as chlamydia or gonorrhea, and is usually secondary to pelvic inflammatory disease. So here, a patient might present with fever and abnormal uterine bleeding. And then in terms of treatment for this one, there's no actual proliferation of the endometrial tissue, so we don't have to use our surgeries, we don't have to use our hormonal treatments. Instead, we simply treat with antibiotics. So for mild to moderate endometritis, we use ceftriaxone and doxycycline, which again are the treatments to cure or get rid of chlamydia and gonorrhea infections. And for severe endometritis, you can use clindamycin and gentamicin. Finally, we have iatrogenic. So causes of abnormal uterine bleeding that are caused by treatments. So this could be due to a person receiving estrogens in the form of an intrauterine contraceptive device, such as the Mirena, or tamoxifen, which is a cancer drug for people with breast cancer. If someone's also receiving exogenous androgens, or if they're receiving anticoagulants or antiplatelets, this can increase their tendency to bleed. Then you have N, which kind of covers all your random extra things that didn't fit into the other categories. So examples of this could include uterine arteriovenous malformations or cesarean scar defects. Because if you have had trauma in the past to your uterus and that causes rupture, you're going to get bleeding. So that covers the palm coin system. Now, just quickly, I'm going to go through the investigations, the drugs that we use, and the surgeries that can be used to treat abnormal uterine bleeding. So quickly, if someone came in and they were bleeding abnormally, as defined here, we would run a bunch of tests. So these are not diagnostic, or not necessarily diagnostic, but they can help to also inform the management of this patient. So to cover things like anemia, we would look in the full blood count. We can look at platelets and coags to look for coagulopathies. We would run a beta HCG to look for whether or not this person might be pregnant. We can also look for thyroid function tests, because remember, hypothyroidism can cause abnormal uterine bleeding. We would look for prolactin levels to check that, for example, a hypoprolactinemia might not be hypoprolactinemia might be affecting our LH, FSH, and hence estrogen levels. And we can also do iron studies to check for excessive blood loss that may be causing an iron deficiency anemia. Now, the most effective and least invasive imaging or investigation is the pelvic ultrasound. So this can be done abdominally or transvaginally, and transvaginal is usually the go. And this is kind of a shitty image, but what you would see is the uterus. And this ultrasound can tell us about structural abnormalities. So structural abnormalities might be your adenomyosis, polyps, or leiomyoma. And in the ultrasound, we can also look at endometrial thickness. So this is very important because this tells us whether or not there might be the chance of malignancy or hyperplasia. And the parameters that are used is that the endometrial stripe, which is this area here, should be less than 4 millimeters in postmenopausal women during the secretory phase, or less than 12 millimeters during the proliferative phase. So this is why it's important to note that you should do this ultrasound after a person's period, so after they've shed their endometrium, so that it doesn't seem abnormally thick and misleadingly thick. A more invasive investigation that can be done is the endometrial biopsy. So, for example, in the case of polyps, if we want to find out whether or not they may contain carcinomas within them. So, endometrial biopsies are indicated for women who are less than 45 years old with abnormal uterine bleeding and a high risk for endometrial cancer, in the form of things such as family history or any of these risk factors. It's also indicated for any person over 45 years with abnormal uterine bleeding, and postmenopausal women with uterine bleeding or endometrial thickness more than 4 millimeters. Now, in terms of drugs, these are usually hormonal because, again, endometrial proliferation is mainly influenced by hormones. So for acute abnormal uterine bleeding, what is used is high-dose IV conjugated equine estrogen. So this triggers rapid growth of the endometrium and hence reduces the amount of sloughing off of tissues and sloughing off of blood vessels. And then for a patient who might be experiencing ovulatory-related abnormal uterine bleeding, you can use the oral contraceptive pill, which would decrease your gonadotropic releasing hormone, decrease LH and FSH, and lead to reduced endometrial proliferation. You can also receive progestin or progesterone, for example, in the form of the progesterone-only pill or the Mirena, and this suppresses GnRH and LH and, again, reduces endometrial proliferation. NSAIDs, we mentioned, is used, for example, in adenomyosis, and this helps to reduce blood loss. Then, in the case of really bad, for example, coagulopathies or extreme blood loss, we can use tranexamic acid, which is a plasminogen inactivator and decreases fibrinolysis. So basically makes your platelets sticky and clots them together. And I'd like to note that tranexamic acid is also used in postpartum hemorrhage, so it's very popular in women's health. We love tranexamic acid, but we only use it in emergencies and for acute uterine bleeding. So in terms of surgeries, the more invasive ways that we can manage someone with acute uterine bleeding. Starting off with dilation and curettage. So dilation and curettage is basically where they use a curette and they scrape away the excess endometrium that's causing the uterine bleeding. So for example, in the case of endometrial hyperplasia or anything like that, this is a method that preserves the endometrium and allows it to continue to proliferate in the future. So it preserves fertility. You can also use a hysteroscopy, which is where you insert and look inside the uterus to look for things like polyps. And this method can be used to remove certain proliferative aspects of the endometrium. Another thing that can be done is uterine artery embolization. So by cutting off the blood supply to the uterine artery, this causes necrosis of tissue and helps reduce the occurrence of fibroids. Then you can also use endometrial ablation or destroyal of endometrial tissue, and sadly, this does not preserve fertility. And lastly, the definitive treatment, as mentioned before, is the complete removal of a woman's uterus, because no uterus, no uterine bleeding, and this is called a hysterectomy, but of course does not preserve fertility. So all in all, when deciding the treatment for abnormal uterine bleeding, it's very important to interact with the patient, talk to them about what they want, about their future plans, and any plans for pregnancy should be taken into consideration so that the most conservative approach can be used. So thank you so much for listening. This has been very chill. I'm about to go to bed. My hair's all dry. This has been great. And I hope you learned something, because I learned a lot. And the next time you're taking a history from someone, write down Palm Cohen. Ask them about the pain, about their risk factors, about whether or not they've had any exposure to estrogen, whether or not they have a family history of endometrial cancer, and whether or not they have any coagulopathies, etc., etc. Because it'll really, really help with your differential diagnoses if you keep this in mind. So, thank you, and I will be out.